Hi, everyone. So glad that you are here. My name is Kayla Fulgenetti. I'm the Senior Director at Elephants and Tea, and I am always honored to welcome you to our next session of AYA Power. This is season 3. Our theme of the season this year is moving forward with purpose. It's still January, so I feel like I can still say Happy New Year to everyone and just really kind of honored to have you all joining in this space, coming together as a community as we continue to just learn how to support our AYA patients and their families and try to just put some good out into the world when we need it. So for those of you that are new, AYA Power is an initiative for training and education to provide the oncology workforce with education and resources specifically to the adolescent and young adult community, brought to you by Elephants and Tea and the AYA Oncology Education Working Group. Each month, as you are here now, we bring an expert speaker to share information on topics that are relevant to AYAs with cancer, and each session is recorded. I want to put this in big bold letters somehow, but if you check out our website, which has just been dropped in the chat, we have an incredible library of all of our past sessions that are available there. So if you are looking for a certain topic, please go check it out to view all of those incredible speakers. They truly are the experts in what they do and offer that education and support. So that is all there for you to be able to look at for free, to send it to your colleagues, to pass it around. So you go to the website and scroll down to the bottom where it says on-demand content, and you can see all of that there. Just a little bit of housekeeping, and then I will be sure to pass the mic over. But first of all, a huge thank you to our sponsors for supporting AYA Power, our founding sponsor, I'm Not Done Yet Foundation, and our supporting sponsor, Eisai Pharmaceuticals. We always are looking forward to the engagement that these sessions bring. So there should be hopefully a Q&A button at the bottom of your screen that you will be able to drop questions to our speaker. And then we really enjoy the discussion portion of this at the end of the talk. It's the opportunity to pick their brain and learn even more. So please make sure as the talk is going on, if you have questions, comments, experiences that you are having, please make sure to drop those in, and we will moderate really a beautiful discussion at the end. Before I introduce our speaker and get us going and stop talking myself, I also just wanted to share very quickly information about our next session, because we are doing a rapid fire power. We have it today and then we have it next week right away. And it's a really also beautiful topic. So on Thursday, February 5th at 11 a.m. Eastern, Dr. Sharon Bober will be talking about sexual health. It's time to address the elephant in the room. So please make sure you join us for that session and also share that with any colleagues that might be interested in that very hot topic that we always seem to bring back every year. So we recognize again just how hard this work is that you all do. So as the short time that we have together, just take a moment and recognize the community that is working to do all of this as we move forward in care for our young adult patients and families. So with that, I have the absolute privilege and honor of introducing Dr. Christabel Cheung. Dr. Cheung is an associate professor with tenure at the University of Maryland School of Social Work and a member of the University of Maryland Greenbaum Comprehensive Cancer Center. A social and behavioral scientist specializing in psychosocial oncology, Dr. Cheung's research addresses health equity in cancer survivorship among adolescent and young adult and early onset cancer patients. She leads community-engaged mixed method studies and is the developer of embodied research methods, a qualitative approach she pioneered for the behavioral sciences and medicine. Dr. Cheung is affiliated with leading research institutions, including Michigan Medicine, the University of California, San Francisco, the Netherlands Cancer Institute, and the University of Hawaii Cancer Center. A very sought-after speaker, which is one of the many reasons we have her here, and a two-time AYA cancer survivor. She's also nationally recognized for her patient advocacy and public scholarship. Her honors include the Kamara Jones Faculty Award at the University of Maryland, Baltimore, and the GRASP Advocate Choice Award at the American Society of Clinical Oncology. She also serves as faculty for multiple National Cancer Institute funding training programs, and we are honored to have you here and be a part of Power. So, Dr. Cheung, I will pass it over to you. Thank you so much.
Thank you so much for having me, Kayla and Lisa Scott. Very excited to be here today. And I'm hoping that there will be members of the community who contributed to this research that I'm about to present to be here today. It's been a long time coming in terms of trying to get this data out into back to the study participants first, and then back into the community. But I'm excited to, this is the first look at what we were able to gather. So we're gathered here today to talk about AYA psychosocial care and the uptake of that care beyond hospitals. So we're really talking about why engagement is an implementation problem and not an availability problem. That was one of the keys to approaching this research. And I just want to share with you that because I am an AYA survivor myself, much of my research, I hold myself accountable to what's happening at the nonprofit level, at the patient level, at the hospital cancer center level, and really like what are practical research questions that need to be answered to improve care. So just really quick, brief thing about, I'm having trouble advancing. Let's see what's going on. Oh, here we go. Before it was advancing without me, so I don't know what that was about. And I'm letting some people in. Okay, so this is just a brief thing about, we didn't really have funding. It's just, we had sweat equity. So Dr. Mike Roth and I at MD Anderson really led this work. And I had the assistance of my doctoral students and graduate students. And we are very open to funding. So I wish I had a funding disclosure more to say, but this was an IRB exempt study. Okay, I don't know why it's so hard to advance, but okay, hopefully it gets better, right? Okay. And then in terms of a background, so what do we mean by uptake? So you might have heard uptake referred to as enrollment, or you might have heard it referred to as enrollment issues or participation, reach, retention. All of those things are part of what we're interested in. So what we found that in terms of the AYA psychosocial care pipeline, these are sort of the 6 steps. Individuals need to first have resources that are available to them, services and supports, right? All of the nonprofit programs need to be available. They need to be discoverable. So an AYA typically now needs to be able to quickly search and find them, or else it's, the information is pushed to them somehow through their social channels and so forth. And then referral. So what we know in the literature is that AYAs, despite being digital natives and despite being able to access online resources very adeptly themselves, they really rely on someone with credibility to validate that the source for them. This is, because of the unique situation of being a cancer patient and being afraid to doom scroll about your own diagnoses and the consequences of it, right? And then there's the issue of fit, and fit is a good way of just simply saying, like, is this a cultural fit? Is this a time fit? Is this a practical fit? Is this a financial fit? All of those things about, like what do AYAs need to do to be eligible to participate? And then uptake is the actual action that we're interested in and the question that we have today. What does it take for us to get AYAs enrolled and to participate in these programs? And then, subsequently, how do we retain them? Retention is the last issue. And what we do know that despite AYAs having very high distress and resources being in existence, there's still this issue of low participation, even though the literature shows that participation results in better outcomes for them. And so we're really interested in the bottleneck in services uptake and how do we solve for that? And so I really would like you in the chat. I have a question and you can think about it and answer this. What I wanted to ask you is, what's the hardest part in your setting in terms of referrals, reach, or retention? I should have found a faster way of doing this. There you go. Okay, so you don't mind responding in the chat whenever you have thoughts. And then it's important to think about, you all know this, the AYA vulnerability, right? This is really a vulnerable developmental period. And what the literature shows is that there's inadequate, still developmentally appropriate information support at the various time points across the course of care, right? So in terms of at diagnosis, during treatment, during active treatment, and in off-treatment survivorship, as well as in long-term survivorship when the late effects appear. So the literature consistently shows that. And yet there are persistent access barriers to follow-up care that can complicate transitions and continuity. And so here are my co-authors, and because I developed an embodied research method for qualitative research and mixed methods really as well, I decided to have, I always have these crazy big co-author teams without ever intending to at the beginning, right? And I love that because it's an organic process. It's always, I partnered with Mike Roth, and the two of us get together and say, okay, here's, of course I'm going to need students to be coders and research assistants to do the practical aspects of the science of it all, right? But at the same time, what's the expert perspective that we need? So we invited folks like Susan Parsons, Wendy Griffith, who's the director of the AYA program at MD Anderson, and then other scholars that many of you are familiar with who provide a completely different, whether it's a pediatric perspective, a psychology perspective, a nursing perspective, or a digital health perspective. We really wanted to include all of that in this work. And so why are we looking at what we're calling beyond hospital supportive care? Really what that is are organizations that exist outside the hospital settings. The real reason why that is that AYAs often receive care in community settings. So we know that from the literature and past studies. And community-based treatment is particularly extremely common for specific diagnoses in AYAs, for example, ALL. And what we do know about the psychosocial care ecosystem is that, for the most part, every single cancer center, I shouldn't say every single one, there's got to be someone that doesn't do this, but for the most part, the majority of cancer centers have some sort of AYA focus, right? Or they say so in their materials. But what that means from one academic center to the next completely varies. And so we needed to create some sort of similarity. And what we found is that so many of these academic centers rely on local nonprofit programs and national nonprofit programs to provide psychosocial support. And these organizations have a lot more in common than if we were to mix in the academic centers. And then in terms of study aims, so this is what we attempted to do. We wanted to characterize what uptake patterns were like and also identify some representation gaps in terms of who are the underserved, right? The underserved AYAs. And then we wanted to come to a sense of elucidating what are the multi-level influences on whether or not an individual participates, and what are some strategies that program leaders have already identified or maybe would like to put into action. And so in terms of designing the study, we designed an implementation science informed qualitative study with an N of 21. And really that N of 21 was practically informed by how many people responded with interest, and also at what point we would reach saturation in terms of repetition. Reaching saturation meant answers repeating themselves in terms of our qualitative data. We employed the framework method for health services research, which means that we used two conceptual frameworks as deductive frameworks. And then within each of the domains of each of the frameworks, we did inductive coding from our qualitative data. And so the two frameworks that we used for our conceptualization of health behavior change were the social ecological model and the theoretical domains framework. I'm sorry, I'm getting tongue-tied. So these are the two frameworks. Many of you are probably familiar with, on the left, the Bronfenbrenner ecological theory, which really talks about how individuals are situated within the context of microsystems of families and communities, mesosystems of larger communities and institutional networks, and then sort of the exosystem, macrosystem, and chronosystem of time that and duration of time that moves around that. So we often think of these concentric circles spinning and interacting. On the right, what we did is the theoretical domains framework is used to understand health behavior change. And so on the left are the 14 domains, and on the right are the definitions of these domains. We use these domains as a framework within which to organize our qualitative coding. So, and then once we organize that data, we then would be able to better understand their relationship. Oh, and we would understand their relationship by mapping these TDF domains onto the ecological theory. So in terms of sampling, we did something different that I came up with and I thought was a good idea. So we did it. We basically used two of our research assistants who are AYAs, but AYAs without cancer, and we asked them to just search and do an environmental scan of AYA programs. And I told them, just go imagine you just got diagnosed and you're just an AYA and just have at it. Go and find what AYA programs exist for you right now. So it was really, really interesting learning. And after we did that, we asked our co-investigators, our investigator team, all the professionals to look into their professional networks, list organizations and contacts that, were not on the list. And then lastly, we had verification by our colleague, Wendy Griffith at MD Anderson, to fill in additional organizations. In total, we have a list of 132 programs across the US and Canada for our sampling frame. And we share that list in our published paper, and we're going to share that list with publicly with everyone, because I think it's actually just a great resource list too of all the organizations that, at that time, it would be as of like December 2024 that were easy to find. And so we contacted all of them, and 33 expressed interest. In the end, we ended up with 21 who actually completed an interview. And I was the one who conducted all of the interviews to create consistency, but I did not participate in coding so that we had inter-rater reliability. So we had 6 research assistants who coded the interviews, and then we all participated in thematic abstraction. In terms of the program landscape, these are the characteristics of our sample. So most of the programs, all the programs were in the US and Canada. We had several in Canada, but predominantly US. And then 12 served AYAs exclusively, and the remainder served AYAs as part of a broader program. And AYAs were, defined broadly as individuals diagnosed between ages 15 to 39, although some of these programs had smaller, more narrow definitions within that age range. And services were always offered either free or at low cost. And so one of our key findings from our interview data was that there are representation gaps. So there are clearly patterns of individuals that these programs would like to reach but are not reaching. And so here's one quote. One program leader said, of the support groups that we have had a male come to, they've never come to a second one. We're backtracking because there's so many X factors. Is it the wrong day, the topics, felt uncomfortable? I don't know. Did you notice? Because this is a red flag. Okay, sit up and pay attention to this. I don't know if this is actually a thing or just what I've observed. So this might be something that many of you have heard about, but yet there hasn't been, with a lot of, what's unique about our study is I believe, and Dr. Roth believes, and our co-authors believe that this is the most detailed study to date in terms of looking at non-participation and lack of uptake and getting this sort of empirical data. And so another quote about representation gaps. So my team is primarily white women. Our board is fairly white. We've really taken it upon ourselves to make sure that there are people of other lived experiences and demographics within other pieces of our leadership, because most of the participants in the cancer space in general are white women. So what I found interesting about this quote and this conversation is this program leader never identified where the other pieces of leadership were that they had the non-white, since this issue was talking about white women, the non-white women representation. They never identified the other pieces where that existed or how that existed, and how that came to be. So I wasn't sure if that was, yeah, I had no other verification of that besides of what this individual self-reported. And so what happened is, initially we started off with a mixed method study. I had people complete exhaustive surveys with their program data to find out the sociodemographics of participation amongst their program participants. But what I found is, and for each survey question, I allowed them to tick a box that indicated they do not collect the data and that actually that answer was a best guess, right? Or an educated guess. And what I found is that that was the overwhelming majority of the data were on sociodemographics was not actually collected, but just what the individual would guess. And the data actually, from the surveys, where individuals guessed what their representation was like, showed greater representation of minoritized populations than what they were telling me in their interview data. So there was a huge discrepancy there. So we came up with this graph, which what it's showing you is that on the y-axis, the vertical axis, you're showing different categories of sociodemographic data. So health insurance status, geography, urban, suburban, rural residents, household income, preferred language, and so on and so forth, right? And so these are categories of sociodemographic data that we asked programs whether or not they collect data on AYAs that participate in those programs. Yeah, about. So, and then across the bottom are the percentage of programs that actually collect data on each of these categories. So you'll see that just over 60% of programs collect data on health insurance status. Around what, 25-ish% collect data on where individuals live, the type of geography they live in. Most collect age at diagnosis, age at participation, most collect gender, race, ethnicity, preferred language, and so forth. So yeah, so that's what that showed. And then but it was the survey data that gave me those bars. And then you'll see, like, as we talk and I share with you the qualitative data, it tells a different story. It tells a story of not capturing those categories, actually. So limited sociodemographic data collection was actually, often framed as a deliberate effort to avoid discouraging participation, and especially when questions were perceived to be sensitive or burdensome. So one leader described here how their organization prioritized minimal data collection while attending to program balance and inclusion goals. They said, we don't ask demographics. I we don't ask demographics. Like, I know a lot of programs do. Sexual orientation, we don't ask. Race, we don't ask. Male or female, we do. That's for housing mainly, and making sure we have balance. We don't want just women programs. We want male and female. We want co-gender programs. So that way we can learn from the other perspectives, and that's what we're all about. And then there was some referral friction and stigma, and those issues of, the intersectional differences amongst participants coming together and creating challenges for program leaders. And some program leaders described limited integration with oncology workflows in referring individuals to AYA programs as an issue for them. So in terms of referral friction with coordinating with academic centers, one individual said, it's difficult to get oncologists and to get social workers to immediately direct people to us. The last thing they're thinking about is getting them psychosocial support. So really thinking of how do we better integrate so that psychosocial support isn't just, an ancillary thing, but something that's a preventative measure that's introduced by oncologists. And so talking more about the intersection of, different minoritized challenges and the experience of the AYAs, this program leader said, when we look at specifically the Latinx community, just fear of ICE, the U.S. Immigration and Customs Enforcement, sharing information about their address, that's come up as a concern, navigating safety planning. And so I think what's important about this comment is that this program leader in particular, in this conversation just felt like unequipped to handle the set of issues that they were dealing with, but yet they were still doing it, but not sure if that their approach was the best practice. And the third key finding, and there's only four, so hang in there. The third key finding is that retention and dropout is multifactorial. And these multiple factors include the timing of program offerings, competing demands, mismatch, being like, not a good fit, and emotional depletion, as well as like where programs are located. So this first quote really talks about you have to go back into the building where you were treated. And a lot of people don't want to do that. It's very triggering. And many of you know that. And the second quote, if someone is working an hourly position and they're working in the evenings, they're not going to be able to come to our programs. There's nothing then for them. And so I think the issue here with this individual, what I recall from my notes here too, is that it was the identification that they have a specific program and they wished that they were more connected to other programs so that there would be something there for that individual, so that there would be a tighter referral and a shared referral network so that you wouldn't have to just say there's nothing for that person, right? And then the last quote, young people leave programs if they don't feel that it's a welcoming place, if they don't feel that they can identify with the other people in the group, and if they don't feel that it's giving them something immediately, right? And I think that, I've heard in AYA program world, like, other workarounds that individuals have, like, people can bring a +1 to the social event, that kind of thing that sort of encourages more participation. But I think this idea of really thinking about whether the program is evolving with the evolving cohorts of AYAs is something that program leaders seem to be aware of, and I'm not sure if they feel like they have the resources to respond immediately. The fourth and final finding, this is sort of the major finding in terms of how the challenges, which are in the center column, that the program leaders identified, which now fall within the theoretical domains, framework domains, how they map onto the social ecological model on the left, right? And so what we're saying is that from left to right, this social ecological context faces these specific challenges at each level in the middle. These challenges interact with each other. So you see the bidirectional arrows as well, up and down, and they all result in a certain psychosocial participation outcome. And that outcome could be a yes or no, right? And so that's how this maps and works. And, thinking of when I think about, I have 8 years of nonprofit experience before I got my PhD. And I think about how if I was a nonprofit leader, I would really like to think about what are the specific challenges. I'd like to name those challenges in the middle for my organization or for my program, and have one chart like this for a positive participation, what that looks like, and one that is like full of challenges that, would result in a negative, no, they're not going to uptake. Okay. And so lastly, program leaders identified strategies that they would love to see if only they had the resources, oftentimes, whether that resource is time or actual funding. And so these were the three main sort of buckets of strategies. First are partnerships and better community embedded outreach. Um, and clinician-facing referral supports and workflow integration. So we really talked about that. So how can there be, with both of these, it's how can there be an infrastructure that the community is networked into that involves clinicians at the academic centers as well? And then, yes, so lastly, a shared infrastructure to not only initiate referrals, but also do an initial needs assessment and intake. So how could all of the providers, whether it's a program leader in the community, a psychosocial provider at the academic center, or an oncology clinician, how can everyone know the needs of that patient across the cancer care continuum and assist with resource matching along the way and coordinating so that data can be collected as well, right? So that we can have an appropriate feedback loop and learn. In terms of community partnerships, leaders describe shifts towards community-embedded recruitment and their own efforts, and explicit attention to avoiding what one individual really labeled as extractive outreach. So the first quote, we're working with community partners, making sure that those programs are led by people within those communities instead of the white savior coming into those spaces. And then most psychosocial program leaders in the study similarly framed discontinuation from AYA programs as a complex multifactorial process that they had yet to evaluate closely. And so what they said is, if we had more money, we could run more programs and more program participants. And I know that they would come because I have a wait list a million miles long. And so this quote really, I think, resonated with many individuals in different ways, but really pointed to how do you do the additional outreach to make sure that the programs are inclusive of the underserved when those that maybe don't need the services as much are full on your wait list and are, like first to show up and take advantage of the programs. So how do you solve for that is a challenge that I think many wish that they had other individuals to partner with to solve. Growing a community of care. This was a really powerful, I thought, insight from one of the program leaders. The breast cancer community, they're tight. They come together, talk to each other, and that opens up. Have you been on this program? Have you heard of this program? They also have programs specifically for breast cancer, camps, programs, creating a culture with a lot of commercialized messaging and, in my opinion, saying, hey, ask for support. We're here for you. That makes it feel normal to seek help. I don't think it says normalize for other cancers because they don't see the commercials or marketing that make it feel routine to look for additional care, even though those resources exist. So when I found this so moving and so poignant, and it made me think, how do we grow a community of AYA care? Right? How do we make individuals think about AYAs the way that they think about breast cancer or other cancers the way that they think about breast cancer? And it's okay to ask for help. I think breast cancer has such a strong and pervasive and widespread platform and patient education, community education that many individuals just in the mainstream just equate cancer with breast cancer, right? And they don't even realize they're doing it. So how do we expand that and uh, learn from that? Clinician referrals and shared infrastructure. So leaders also described limited integration with oncology workflows, as I mentioned before. And this is how they described it. It's difficult to get oncology. Oh, wait, I already did this. Right. Yeah. The last thing they're talking about is psychosocial support. Excuse me for repeating that. So the second one I haven't shared yet, there's not an easy way for hospital staff to be able to use AYA psychosocial resources. I wish there was a universal needs assessment linked to the relevant resources from a purely objective standpoint. So yeah, so how do we share that information and meet all of the HIPAA regulations and all the patient privacy concerns and so forth? That's, a question that many individuals had. Implications for practice. So what we learned is that what clinics and community programs can do is make referrals low effort. So for example, EHR prompts, scripts, handoffs, warm referrals when possible, like greater relationships around referrals with community programs, and treat needs assessments as serials. So treat a needs assessment as not just a one-time only event, but one that is repeated at key transition points and to revisit it over time and into long-term survivorship. And the next learning is standardize a minimal ethical equity data set. So what this means is to have a purpose statement and a clear, conflict of or a clear disclosure statement so that when you're consenting individuals, it's clear the purpose of that data collection and that everyone is on board or understands the rationale for having that information. And the ability to skip options in collecting the data is something that someone raised, and just a trauma-informed framing of data collection in terms of approaching AYA so that it's not off-putting and doesn't prevent them from, it doesn't encourage treatment non-adherence and so forth. And then reducing participation friction. So practical things that we've already mentioned, like timing options, asynchronous pathways. So not necessarily saying like, now's the time for you to think about whether or not you want a certain type of psychological support, but offering maybe the online support groups at various points, checking in about childcare transportation needs because that may be changing. So that kind of looking at issues that might come up that relate to participation challenges for the individual. And then build shared resource matching infrastructure with community partners, which we already talked about. The key takeaway. So I was thinking if there were only 3 things that you remembered from this talk, it's to remember that uptake is the bottleneck. That's the problem, right? And so it's not the availability of programs. There are lots of programs available. Uptake is the issue. And so what it does say about the programs is that maybe the programs are not a good fit, but there are programs available, right? And when it is possible to make referrals are being made. Whether or not it's an appropriate referral is another issue, right? So I don't want to conflate this to say that we have all the AYA programs that we need, because we don't necessarily. There might be still a need to create additional AYA programs. But all I'm saying is that there are places available for clinicians to refer individuals at this point. And then equity requires visibility. So this issue of like not asking certain things because in an effort to advance equity is questionable, right? Because how you know that that's happening too if you're not collecting the data. And so yeah, you don't, oftentimes you don't know who's not coming. And data capacity really, like, it's we can do it in such a way that it promotes trust and improves the outreach of these programs. And then lastly, shared systems. So right now it really does depend on the overextended clinician to do something heroic to refer. That's this point about shared systems beat heroic heroic labor. It shouldn't require that heroic labor of the thoughtful clinician, the overextended clinician to refer to a psychosocial program. We should make that transition seamless. And limitations, we did only focus on, community-based and nonprofit programs that are beyond the hospital. And so that limits our ability to talk about integration with academic centers and within, hospital sectors. And let's see, we have limited patient perspective. There were some individuals who were survivors themselves who participated in our study, but we were interested in program leaders. And in terms of clinical trajectory data, we were limited in terms of what organizations captured, right? And so I mentioned to you there wasn't there was inconsistency in terms of what people were actually able to collect. And then for future studies, we really hope to continue this work and look at cross-sector referral pathways with hospital academic centers. Wouldn't that be so great to be able to share resources and to have a network that everyone can plug into is something that really resounded and came through strongly. And survivorship transitions, we really need to define what that looks like for the various types of programs, right? So the our sampling frame of AYA organizations, the 132 that we listed, we also checked off what types of programs they offer. So really excited to share that with you all. But so how do we then share that information across the survivorship pathway? And then institutional supports beyond diagnosis, really not just looking at the acute diagnosis period, but well beyond that is something that came through strongly. And yeah, let's talk about it. Happy to take your questions. And these are some questions that I had for you all. So thanks so much for listening to my talk, and really excited to hear from you. And my contact information there is there too. Happy to connect with you. And for those of you who may have participated in this study, sit tight. We're gonna get back to you with all of this information and share slides and all this stuff and other graphics that I promised all of our participants in the absence of any incentive. I wanted to provide information back to the community so that you all can use it for your own grant writing and program development. Thank you.
Thank you so much. That was an awesome review of all the amazing work that you've been doing. I want to open it up for questions, so please feel free to put them in the chat or the Q&A function, or if you would like to, you can come off mute. I'll leave it there for a second for everybody while they're thinking. So while everybody is thinking, I have a few questions for you that we've been asking all of our speakers this year, and really trying to think about kind of moving forward with purpose. So where do you see the field of AYA oncology really going in the next 3 to 5 years, or where do you think it needs to go in the near future?
Well, there's all this attention on early onset cancer, right? And so I think definitely that, right? From in terms of interest in etiology of illness and diagnosis, why suddenly are there so many? So just a quick thing in terms of definition, so we're all on the same page. So there is like a shared Venn diagram of the EOC, early onset cancer, and the AYA cancers, but it's not just so early onset cancers are individuals diagnosed below the age of 50, and then AYA cancers are individuals diagnosed below the age of 40, right? But the early onset cancers are not all the individuals diagnosed below the age of 50. There are the individuals diagnosed below the age of 50 with cancers that typically occur later in life, right? The breast, colorectal, lung, prostate, ovarian, that kind of thing. So there's all this interest, particularly in colorectal right now, and so I feel like AYA oncology can really partner with this interest in early onset cancer, a lot of interest in the gut microbiome. And I think this really speaks to longer term survivorship too, right? So how are people diagnosed so young, and what can they do in terms of um, cancer control afterwards to live a long, healthy life?
And given today's challenges, what creative ideas or partnerships do you think can help us improve care?
Um, I think that like really genuine community partnerships can help improve care, rather than the token, like I need one person from this group, one person from that group, one person from that group. I think really thinking about like, oh wow, look at all the people in, let's say, that are driving um, to our social events from this particular suburb. Like, let's get in touch with that community, and how can we like maybe do a ride share from that community? So I think things like that are really organic are what sticks, and you naturally improve the representation that way, right? Rather than just like, well, there's a mandate that I have to check off these boxes. I think that those are just they're not it's not organic. When it's not organic, it's not a good fit. I think about, I often draw analogy to things like when HUD housing has to be reflective of the national percentages, but it's situated in a certain neighborhood. I used to work in senior affordable housing. It has to be situated in a certain neighborhood. And so, like, for example, when I worked in Chinatown, not everyone wants to live in Chinatown, but that Chinatown HUD housing had to be representative in a lot of instances in a certain way, but our Russian seniors would prefer to be in a different building, and they'd just be hoping and hoping and hoping. And so sometimes I wonder, and I think about, and I don't have the answers to this, like how, like, perhaps things would be improved if we just reflected what people want. And are we just, because if we continue to be fearful that, like, oh, it's going to just fill up in a certain way, then we're never going to find out, right? And so what happens if we do respond to just like our gut instincts of what we already know? I think what I've learned from this study is our program leaders in the existing AYA oncology community know a lot. And if they had the resources, if they had the infrastructure, if they had the access and the information to respond to their gut instincts, they would be able to serve our AYAs a lot better.
I love that. It really drives home that mantra people say, nothing about me without me. And really kind of, which I think that we represent a lot within AYA care, and but kind of really driving that home and thinking about it very intentionally across the board of the stakeholders.
Mm-hmm. Yeah.
And then the last question that we like to ask everybody, and then I know that there's some questions and hands raised, is what is one thing that we can do? We have this great group of people with, 50 people logged in right now. What is one thing that we could do as a group or as a community together to make real progress now?
I think right now we're in a very difficult geopolitical context. And as someone who, I'm on the professor watch list, I'm harassed and followed by Turning Point USA and Charlie Kirk's squad. So it's a very difficult time to be doing this work of being inclusive. And but I also, like, I was a nonprofit leader during when the Obama administration came into leadership. And I always use this as a hopeful example, because so I was the director of diversity at the American Society on Aging and this was during my first diagnosis of cancer too, in 2008. Obama came into the presidential office, and I was the director of diversity for the American Society on Aging, and I was leading all of these racially minoritized leadership programs for people that wanted to become national leaders and learn how to lobby on the Hill. And what happened is, because we had a Black president, we entered the post-racial era in funding. And so all my funding went away because we decided that we had solved racism because we had a Black president. And I got restructured out of my position. And we decided we didn't need diversity anything anymore, right? And then George Floyd happened. And then there was this racial reckoning from many predominantly white institutions, right, that were self-conscious and they, and so what I like to say to people is that, like, don't worry about the emotional highs and lows of the geopolitical context. We've lived through this before. For those of us who've been doing this work of inclusivity, we're committed to the patients no matter what, no matter who the patients are. And I think that like during that time, I was like, especially like during the racial, when we went post-racial with the Obama administration, I kept doing the work. I just had to use different words and call it something else. So this thing of using different words and calling it something else is not new, right? It evolves over time, and it's okay. Like, I'm not threatened right now. My work has not changed at all. I'm still serving the same people. At the end of the day, we're all about cancer patients. How serving cancer patients has become, like, controversial is, like, beyond me. But we're all here for the same reasons, for the same patient population, and so I think that's the creative thing, that the AYA community can be a model for how we consistently serve the same population regardless. And I think we did a great job of that over COVID, where everyone so quickly transitioned to virtual healthcare. And AY Oncology did such an excellent job of continuing to serve patients. So yeah, so I think that's what we can do.
I love that. Thank you.
Mhm.
Um, Betty's been really patient. Thank you. So I'd like you to invite you to come off mute and ask your question.
Thank you, Christabel. Fantastic work. So many things you said I love. Serial needs assessment. I really don't have a question. I just got to lift you up here. Serial needs assessment is so imperative to taking care of the person with cancer. So thank you for calling that out. Gut instinct. We need to give permission to our clinicians to use their gut instinct more often. So thank you
Mm.
for saying that as well. You are experts. All these clinicians that are on this call, you are experts because you see the patients every day. Please use your gut. And then I would also like to say, do you know Brittany Hall's work on the AYA Cancer Care Plan out of UT Southwestern?
No, I don't
Okay,
think so.
I just dropped a link into, I think, what might be one of
Perfect.
the last publications, but Mullen She has taken over her work there. And if you would like to be connected to her, I'd happy to do that. But the care
Thank you,
plan
Betty.
used the AYA needs assessment from Canteen, which is loosely based on
Okay.
the NCCN problem list,
Mhm.
where the endorsed issues then had an automated, I think, 3 resource referral sent to them through the EMR, I believe through the patient portal. So please reach out. There's some work already being done, or there's some work that has been done, and let's not reinvent the wheel. So I think that could pair well with this work you are doing.
Yeah, and I love that point, Betty, about not reinventing the wheel. But the thing is, we're not using the wheel.
Right. The
So
wheel gets
so
put on a shelf.
like it was a shock to me. It wasn't until I like researched it that there are so few cancer centers that actually use the distress thermometer and the problem checklist on a consistent basis, even though it's mandated, right? And because there's no
One time.
consequence for not doing it, right? But it wasn't until I really, studied I wanted to use it for a financial hardship study because I thought there's already a problem list. Like this is in front of every clinician already. We don't, because in my mind, and one of my mentors at one point, as a trainee, I had all these ideas for all these prompts for the EHR, and my mentor said to me, Christabel, this is going to be insane. The person's never going to get to the patient because it's going to be a million prompts. And so I think we don't want every single study is another prompt, like, and so there's that. But yeah, there, like to your point, there's these existing things. So how do we remind people how to use it? And I think this is a great time to do that because we don't have funding for brand new innovative things, right? And so here's this sheet of paper that you've been using. It's a simple item checklist. And if we had that for every single patient, and if the nonprofit community could connect to have access to that information, we would solve so many issues. Thank you.
There was one question in the chat about the list of nonprofits. So if you have that, if you can post that in the chat for us or just remind people where they can get that.
Yeah. It's our manuscript is under review right now. So it's one of the supplementary tables in that manuscript. So it will be made publicly available very, very soon. And but you can also email me if you want that list. But I'm definitely circling back. That was the very, very soon with and I can share that list with Elephants and Tea as well, so that they can share it with the list
Yeah.
along with my slides and all of that. So it's not a
Yeah.
problem.
So for everyone on the call, we usually, in addition to the recordings for the on-demand content, we do also put resources and tools. So we'll definitely add that to it once it's available.
Yeah.
All right. Well, thank you so much for this incredible talk and really going through based on your experience and the research and everything. So thank you again for joining us today. And I'm going to turn it back to Kayla for some wrap up.
Amazing. Christabel, thank you so much. Just to echo Scott, really appreciate you being here and providing this perspective. I think that this is As you said, the manuscript's in review, and so this is kind of new hitting information, which is such a privilege for us to have and to see this coming out. So thank you for being here and being a part of it. I am going to drop just a few more things. The survey, as we always collect your feedback about how we're doing, what you're interested in, ways that we can improve. So that link is there for you in the chat to let us know. And then just to remind everybody as well, the next session is going to be next week. So next Thursday on the 5th at 11 a.m. The topic is sexual health. So if you would love to come back and join us for that, we would love to see you there. As Scott said, this recording will be up on our website as part of the library that exists. You'll also get an email follow-up when it is available. So share it with colleagues who might have missed the opportunity to be here live, and just a huge amount of gratitude to all of you for being in the space and doing the work that you do. Again, thank you, Christabel. Thank you, Scott. I know Mike wasn't here, but thank you to Mike. We always have to name drop him too, because otherwise he might get upset that his feelings hurt that he wasn't talked about. So we'll talk about Mike too. Thank you all so much, and we will see you next week. Take care, everyone.
Thank you.